Well, hello everybody, and welcome to the Twitter space. Thank you for joining. What we want to talk about is why gender equity matters. In particular for Frontline AIDS, it matters because we believe that it's needed to reach our vision, which is to end AIDS by 2030. So why do we want this, and why is it so important? Because the barriers to end gender equality are the same as those to end AIDS, and we want to turn the tide around HIV because it matters. Just so I'm going to some technical issues. So what I'm going to do right now is we move on. I'm going to introduce you to our panel. First person I want to introduce to you is Joyce Ouma, and she's from Y Plus Global. And Joyce is a young woman living with HIV and is the Advocacy and Campaigns Officer at Y Plus Global. And Joyce is passionate about the ethical and meaningful engagement of youth people in all diversity in key decision-making spaces. And Joyce is pursuing her Master's in Gender, Women and Development Studies. Our second panelist is Dr. Ntotleng Mabena, and she's from NACOSA. She's a medical doctor with a master's in public health and postgraduate diplomas in HIV management, tropical medicine, and forensic medicine. Dr. Mabena has 18 years of clinical and advocacy experience in GBV, SRHR, and LGBTI health program management and implementation, capacity building and training, and research and evaluation. Dr. Mabena is NACOSA's GBV technical specialist and leads their work in decentralizing post-violence care. Then we also have Amrita Sarkar. Amrita has been for the LGBTI plus community and especially for the transgender community for more than 2 decades, and has been involved in numerous capacity strengthening initiatives for the transgender community at the national and international level. Amrita is currently working as the advisor, the Transgender Wellbeing and Advocacy at Alliance India in Delhi, and she has been part of the core working group formed by the National AIDS Control Organization in India to design trans-specific intervention programs, and NACP, IV, and V, which is the National AIDS Control Program in the phase 4. She's one of the founding members and at the secretary of the IRGT, a global network of trans women in HIV, and she's a member of Transgender Professional Association for Transgender Health, IPATH, Indian Professional Association for Transgender Health, and also a faculty of World Professionals Association for Transgender Health. And then lastly, we have Patriciah Jeckonia, who is the Senior Technical Advisor for Policy and Partnership at LVCT Health. Her background spans the field of capacity development, organization system strengthening, policy advocacy and strengthening partnerships, especially with communities. Her specific interest is in advancing evidence-based approach to development of policies that address system gaps for improved access to services. And she has vast experience in working successfully with current government. I'm not hearing anything, so no complaints. I hope my system is still up and running. But just to get the conversation going, I turn to Joyce and just ask Joyce, what does gender equity mean from a young woman's perspective? And can you just highlight to us how inequalities propagate new HIV infections and why young women are more infected by HIV? Okay, over to you, Joyce.
Wow, thank you so much, Yumnah. Hi, everyone. Thank you so much for joining, and most importantly, also for having me on this panel. To answer your first question on what gender equity means from a young woman's perspective, I think I wish I knew, because I wish I lived in an equitable world where women and girls have equal access, have equal opportunities as boys and men. The mention of gender equity brings to mind how disproportionately young women are affected by the HIV epidemic, for example. And it simply sounds, how young women are disadvantaged as compared to the others in the society, especially in sub-Saharan Africa. Generally, equity is about fairness. The mention of the word equity brings, the thought of fairness and how each and every one of us have the right to be treated with fairness, regardless of what we identify as or who we identify as. Gender equity is women are affected by the HIV epidemic, for example, and it simply sounds, how young women are disadvantaged, as compared to the others in the society, especially in sub-Saharan Africa. Generally, equity is about fairness. The mention of the word equity brings, the thought of fairness and how each and every one of us have the right to be treated with fairness, regardless of what we identify as or who we identify as. Gender equity is an uncomfortable discussion that the privileged don't really want to discuss, as it will destabilize the status quo. But for women, and especially for young women and girls, gender equity is the goal, because gender equity means it provides a sense of belonging. It provides us a right to claim your rights, and it also provides an opportunity for equal access, affordability, accessibility, and control of everything, of all resources and all commodities that are available for use. So how inequalities have propagated the new HIV infections among young women, I think this is something that is very obvious. I'm looking at the attendees of this call, of this space, and I see a lot of people who have been seasoned in the response and who completely and totally understand how inequalities have constantly affected adolescent girls and young women, especially in sub-Saharan Africa. The UNAIDS data shows how women and girls are disproportionately affected by HIV, with more than 63% of new infections being amongst women and girls. And this has been the case for a very long time. And you would expect that this would, cease with time, but it keeps going on. It keeps, building up one after the other. And why is this? Simply because if I walk into a facility right now as a person, as a human who identifies as a woman, seeking a HIV prevention option, for example, I will be given a male condom. I do not have a penis, but I will be given a male condom because, number one, the male condom is available. Number two, the male condom is, I don't know, it's definitely something that is easily accessible. The male condom is available in condom dispensers. It's available in shops. It's available everywhere. But how about the female condom? It's very rare to find the female condom being sold anywhere or even being offered freely. And these are some of the inequalities that we are talking about, that for some populations, there is better commodities, there is better services, there is better treatment, but for some, there isn't. I'll give you another example. The male condoms have evolved in texture, in sizes, in flavor, but the female condom remains the same old. So this is one key inequality that constantly bothers me as a young woman, even though I'm already living with HIV. This is something that I'm constantly looking out for and hoping for the day when, more women centered and more women-friendly HIV prevention options will be available. And by this, I'm giving an example of the dapivirine vaginal ring, which is something that young women have been constantly talking about. For those who do not know, the dapivirine vaginal ring is the first long-acting HIV prevention method that has been made available. It's discreet, it's self-controlled by the women themselves, and it goes on for up to 28 days in the system. It's non-systemic and therefore has very limited side effects. But this dapivirine vaginal ring, which is woman-centered, is not available. And this says a lot about the intention to, to support women, the intention to, reduce the HIV incidences amongst adolescent girls and young women. Because in as much as we proclaim and in as much as this has been said several times, this is not being put into action. I started by mentioning that the issue of qualities and inequities come up as a result when looking at the access, affordability, and availability and accessibility parameters. These are things that are largely affected by the inequality, considering we come from patriarchal societies, where some populations are considered better more than others. I think I would also like to mention that in Kenya, for example, we've had many cases of young women being used to track their male partners to go to the facility. So you walk into a facility today for your own health, to seek your own support, but this particular doctor, this particular healthcare provider is concerned about your partner who is not there at the facility with you. And therefore, you find that young women are being forced to disclose their HIV status, and some of them are even exposed to gender-based violence because then they have to tell their partners what they were doing in the facility or at the hospital. The Global AIDS Strategy really highlights inequalities, gender-specific inequalities, as some of the most dominant barriers, whether structural, whether biological, whether behavioral, they're the most dominant barriers, and that will make us not attain the 2030 targets. And therefore, the Global AIDS Strategy main target is addressing these inequalities as the only way to end AIDS. But at this space, I'm not really sure if that is going to happen. But I'm also very excited that we're having conversation ahead of the International Women's Day, because then this is the one day that really spotlights these issues that women continue to go through. Women experience poverty. Women do not have access and control to essential commodities and resources that may place them better to make decisions and to have autonomy over their own lives. And this to make young women, especially, to make part of the highest HIV incidences in the region. So I think gender inequalities continue to drive unequal power dynamics, and we need to have a robust conversation, very open, very honest conversations on how we want to address the gender inequalities, and be very intentional by meeting the needs, the specific needs that adolescent girls and young women have put on the table, to ensure that they, they're not remaining disproportionately affected by HIV. Thank you, Yumnah. Over to you.
Thanks, Joyce. That was, I think for me, the one thing that really stands out, and it's something that's going to come up a lot, and people don't like the word, is the issue of patriarchy and the consequences and impact it's had on society. Just the whole issue of vulnerabilities, the whole issues of inequalities, just how men have been able to get everything right, and women always just had to come in there and be subjected to whatever is available for us. And give you an example on the condoms, something I've also always just wondered about, and why we're not making enough noise around it. And I'm hoping that the global AIDS strategy is really going to help us aligning and align to ending inequalities. But now I want to move over, just talking about vulnerabilities. I want to move over to speaking to Dr. Ntotleng. And in particular, I know that in South Africa, there's the vulnerability to GBV has been, gender-based violence has been a big problem, and we're working towards a strategic plan, implementing a strategic plan in South Africa, but the marginalized people in South Africa is still experiencing a lot of sorry, is there a technical problem? I'm sorry, just my device. So getting back to issues of gender-based violence and the concept of power, Dr. Ntotleng, what does this mean, the concept of power? And is it really and who holds power? And is it really a pervasive concept? And what are your thoughts around issues of power and in particular gender-based violence? Over to you.
Thank you very much, Yumnah, and thank you to Joyce for unpacking the issues around vulnerability and inequality so well for all of us to be able to have this conversation. I really think when we talk about gender-based violence and HIV, we often tend to think about gender just as a concept that only affects women and girls, instead of looking at it as a bigger picture. Looking at the social construct of gender and how it impacts different kinds of human beings and bodies. We're looking at vulnerabilities more than the gender or sex or biological sex of a person. We're looking at the vulnerabilities that make people more vulnerable to getting HIV, make more people vulnerable to being victims of violence. And we're talking about women here in general. We're talking about Black women, especially, who bear a lot of brunt, especially when it comes to violence. We also talk about queer-bodied people. We talk about men and too, who are also victims of this patriarchal system that is based on toxic masculinity. We can't talk about gender-based violence, as you've rightly said, without talking about power and power imbalances. And I really think we need to start having more conversations to unpack this concept of power. What do we really understand about the concept of power and privilege? How does it affect people's vulnerabilities? How can we use it as a tool to build people's agency, build people's autonomy, instead of using it as a pervasive tool? I think we all, in one way or another, experience privilege or experience power in certain aspects of our lives. Even as myself, as a Black woman, I experience privilege and power as being a doctor, as being educated, as being somebody who's well spoken in English. How do I use that power and privilege as a tool to help other people to build their own agency? We start using power as a tool, as a healing tool, and not as a pervasive tool that controls, that belittles, that, but we start using it as something that we use with compassion, with kindness, with love, with gentleness, so that we can start healing people, healing different people in different ways. In South Africa, at NACOSA, we have a program called No Means No. It's a program and intervention that we implement, that we um, roll out to girls and young women, to empower them, to build skills, assertiveness skills, mental assertiveness skills, verbal skills, and even physical assertiveness skills, just so that they can be able to assert themselves better, build agency, and when they find themselves in difficult situations with people, they are able to stand up for themselves. We've also, our program is largely focused at girls and young women. Obviously, as Joyce has already said, girls and women are disproportionately at higher risk of gender-based violence and also HIV. But we also have a component of the program now where we are implementing a No Means No program for boys, because we see that it's important. Boys are not always taught how to use the power that they inherently have in a way that helps other people, that protects other people, that extends grace, that extends kindness to other people. So this program that we are implementing for boys in South Africa is to start breaking down those walls and barriers again, and not just having programs for girls and build agency in girls, but also to build agency in boys and help them to use the innate power that they have because of patriarchy for the betterment of society. I think I can continue more and more, but I think I've made my point to say that we need to start having more conversations about how do we view power, and how do we make it less toxic? How do we make it not a pervasive tool, but how do we start using power as a tool for healing, and a tool so that we can then reach this gender equity that we talk about, this fairness that we talk about, without people thinking that you are taking something away from me so that you can have, but we are sharing this power, and we are sharing resources, and we are all having access to HIV prevention methods equally, as we need it. Thank you.
Thank you, Dr. Mabena. And I think I love the concept of power as a healer. I think it's time we flip it and we start saying, power is not necessarily a bad thing, but it's, how do we do this responsibly? How do we use this power in a way that our societies are going to become transformative, and that it's going to be reflected in our policies that we have. It's going to be reflected in the way that we live our lives with each other and engage each other, and how we live out our rights and access our rights with the freedom we need, with using positive power. And on that, I actually want to hand over to Amrita, because Amrita's got a vast experience, living life on the other side of being violated as a trans woman, but also being able to go ahead and use power in a way that we can ensure and we can continue to make sure that the rights of everyone is adhered to. Amrita, over to you.
Great. Thank you, Yumna. And first of all, I want to wish all my colleagues and friends and whoever you are listening from different parts of the globe that wish you all a happy International Women's Day. And thank you so much. So I'm directly coming to the topic. So before that, I will also explain, I mean, if from my point of view, what is gender equity? Definitely, we have to have, the definition of woman. I mean, the earlier days definition of woman means only female assigned at birth. But now, these days, while we are working intensively on healthcare, intensively on diverse population, we are well aware that women are identified not only based on the sex assigned at birth, but also women with color, women with disability, women who use drugs, women who are in substance abuse, women in sex work, women in with HIV, and definitely women with non-binary identities like me. I'm a trans woman. And these are the identities usually we understand or do not want to understand, and there create the gaps, not only among ourselves but also I think the main service areas, because most of us, we are working in the healthcare sector, and we have seen the movement. The problem was so pathetic. I mean, if I'm a trans woman, there are like separate, say, systems, or like some kind of a discrimination is always there. If I look back our past in India, the HIV/AIDS movement, I mean the HIV/AIDS intervention, actually helped the trans identified person to come out with their identity, because earlier days we were counted under a larger MSM umbrella. And later, government also realized that their issues, I mean, trans people issues, are something very different and unique from the other sexually marginalized population. There it started that just slowly working intensively, as it was mentioned in the beginning of this session, that I myself was associated to design with trans specific intervention project in line with National AIDS Control Organization. Seen the problems, I mean the discrimination and harassment this population is facing. I mean, till today, even when we have a transgender person protection of right act in our country, I mean, even to today, people from my community get harassed at medical access and healthcare, because people do not have much kind of sensitization and awareness. We have already started the process. I mean, people who are associated with healthcare sector, I mean, from the community for a long time. I mean, yeah, it is so timely that I can mention about it. And last week, it's itself, we organized a 3 days long training for different three batches of ground level staff, nurse, and the doctors of All India Institute of Medical Science. They are going to create a center of excellence for transgender health. But everyone admitted that the problem begins when a person, a trans person, is taking entry in a hospital or some kind of a similar facility. The guard has asked so many questions. When I'm at the reception counter, then they don't know about my preferred pronoun, my preferred gender role, or the documentation system is not proper as it should be. Then it's coming to the doctor and nurse, and definitely all these things are specific and very much important for our community. So in terms of equity, I want to see that diversity is respected, inclusivity is respected. Otherwise, there is no point of talking about equality or equity. And definitely, the problem I have talked about a lot, and I think also it's a time to that high time actually to think about how we can address this, because when we look at the trans population in different parts of the globe, either we do not have proper data, I mean sufficient data, people who are facing gender-based violence from a community, lack of data or lack of reporting documentation, even in terms of the number of my community members, that is not reported properly. If I talk about not only HIV but other communicable and non-communicable diseases, hardly you can find the breakups. So all these things are problems definitely, and only way, I think there are two ways actually, not only to build the capacity of the community or the organization who are working for the trans people, but also at the same to bring changes at the policy level. And how we can do that? Definitely we have to work in line with the government, in line with the health ministry, in line with the National AIDS Control Organization, involving the community. I can give you a very good example that recently our AIDS Control Organization has published a white paper on comprehensive integrated healthcare for the transgender people in India, where I have contributed to. So I think these are the some methods where we have to involve community, we have to train the healthcare practitioners, and at the same time we have to bring changes at the policy level, involving the community absolutely. Then we can talk about equality or equality. Thank you.
Thank you, Amrita. That's so important, because we need to be active and we need to be able to be in charge of our own data, and also at the same time be in charge of that narrative that we want to get out there. And talking about narrative, I think I want us to talk about what it is to live with a particular disease, and how that disease actually owns us in a way, and instead of looking at the individual, we actually see the disease rather than the person. And I want Patricia to help us unpack some of that in the context of FGS and linking and the HIV linkages to FGS. Over to you, Patricia.
Thank you very much, Yumnah. And I just want to begin this by talking about a girl by the name Rachel, a woman. She has been married for the past 6 years. She's been trying to conceive and she's not been able to. So the husband has brought in another wife. Rachel has to wake up every morning to go to Lake Victoria, do her dishes there, wash her clothes from there, spend most of her day there doing a lot of the cleaning and house chores. And for all these years, Rachel has no clue what's happening to her. And this is not just a story of Rachel, it is a story of about 56 million women and girls in largely sub-Saharan Africa. These are Black women who live in very poor settings, mostly rural areas, where they are also not so much empowered economically. And because of their continuous exposure to fresh water bodies where they are exposed to possibilities of being infected by bilharzia, that is also known as schistosomiasis, they go on about their days without really realizing what's happening to them. So today, as we reflect on the inequalities, I want us to think about these women whose condition is referred to as a neglected tropical disease. And the question I constantly ask, is it really the disease that's neglected? The disease is carried by a human being. And so when we neglect the disease, we are neglecting the person. Women who have been affected by the female genital schistosomiasis, which for the purposes of this call, I will keep calling it female genital bilharzia, because in the work we have been able to do to try and integrate FGS services, we have realized that a name can also put people off. It makes people feel it's complex and it doesn't affect them. But when we begin to use the language they are used to, then people become alert. So women have a right to make decisions around their sexual and reproductive health. And it's unfortunate that the reproductive health of women is usually not very much funded and has major disruptions. The laws, the policies, budgets do not also favor, to enable the women to be able to access the services they need. But even with these numbers, 56 million may not mean anything to somebody. And many times, as I always say, HIV may not mean anything to someone until they get to interact with real people who have real stories about these diseases. And for me today, as I reflect on this, I'm really thinking about all these Black African women who continue to be disproportionately affected by the female genital bilharzia. And they suffer certain symptoms that they also do not seem to understand. And when they go to the facility, the providers are equally they're equally confused, because every other time these women go to the hospital, they are diagnosed with STIs and they're given antibiotics. There are women who have been on antibiotics for the longest time and they can't explain what's happened to them. So as we think about them, let's also think about the providers who, when they're being trained, bilharzia is just mentioned. They are not taken through how do you diagnose female genital bilharzia, what tools do you use, how do you help this woman? And yet when we are talking here, the treatment of bilharzia is cheap, it's affordable, it's available. It's a tablet that is used especially to be able to prevent bilharzia within the communities. It's known as praziquantel. And it is the same one that is also used to treat FGS. And yet, as long as these women continue to go to the facility and keep getting the antibiotics, they keep suffering the consequences, or rather, the complications that come with FGS. And some of the complications include infertility, ectopic pregnancy or miscarriages, involuntary urine when they are coughing, when they are laughing or jumping, genital ulcers. It increases their chances of even getting cervical cancer and tumors in the vulva or the vagina. And with all this, they experience vaginal discharge, sometimes bleeding after intercourse. It means that for them, sex is not fun. Sex is not enjoyable. They suffer a lot of pain. They have genital itching and also pelvic pain. Now, with the lesions, it means that a wider surface area is actually exposed. And this increases their vulnerability to HIV and even the human papilloma virus, HPV infections. Today, as we talk about the inequalities within our health systems, We are also talking about the inequalities these women suffer. Their social life is never the same. A number of them have been chased from homes because they cannot get children. They have been ostracized out of their communities. Some of them do not have friends because if I cough and urine passes, it means that I also have a smell. So my social life has totally been changed. For us women, equality also means building resilience. It means identifying constantly these barriers and bringing them down. It means for those of us who come from a point of privilege, offering our shoulders so that these women who suffer FGS can be able to stand on our shoulders. It means speaking out. It means fighting for them. It means looking at our systems and seeing why is it that we have 56 million women who are suffering from this disease, and yet there is no sufficient resources. The healthcare providers are not able to give correct diagnosis. They are not able to get treatment and live their normal lives like everybody. As we talk about the International Women's Day being celebrated tomorrow, we are focusing on innovations. We are focusing on technology. For many people, innovation may mean a new thing. Today, I also want to just open our eyes that innovation can just mean an improvement. It can mean just that extra effort that we put so that FGS becomes a standard package in the sexual reproductive health package that's offered to women. And integrate, if FGS has no money, yet cervical cancer has money, why can't we be able to do the same diagnosis? It's the same woman. So we need to rethink on how we utilize technologies that are already there, utilizing digital platforms to create awareness, to offer telecounseling to women who are suffering other mental health challenges because of the long-term, suffering from FGS. With the limited evidence around FGS, it is also time that we use technology to be able to do baselines and get to know exactly the distribution of FGS, how women are affected, and what we can collectively do together to be able to reach out to majority of these women who are less educated, less economically empowered, and they're largely the domestic workers. So it means that even in terms of finances to access complex services, they are not able to. So those are my reflects afternoon as we think about inequalities. We have women that have been forgotten because we forgot about female genital bilharzia. Thank you. Over to you, Yumnah.
Wow, thank you. Thank you so much. Some really powerful messages coming through. Looking at the person as being neglected rather than a neglected disease. Power as a healing tool. Building our narrative as transgender people, put our information, not what you think our information is. Young women still bearing the brunt of HIV. Wow. I'm going to open this up now for questions and comments from our participants. Please go ahead and put some questions in there. Thank you so much to our fantastic speakers. Steve, are there any questions? Any questions from any of the speakers, on the participants? Ntotleng, you wanted to say something?
Sure. I just wanted to thank all the speakers who've really just painted the picture so nicely, and I really like a lot how Patricia pointed out to us that at the end of the day we are talking about human beings. That it's making me think that we are talking about the inequalities within the health system. Again, the health system is a system that is run by human beings. We are talking about inequalities, about diseases, HIV, FGS, queer people not being treated. We are talking about human beings. We're talking about DVD perpetrators, again, human beings. So again, it just takes us back to how do we not neglect human beings and start putting the diseases, in the forefront, or the systems in the forefront, without realizing the human beingness of the people who are in the system and who are benefiting or who are being disadvantaged by the system. So I just really wanted to acknowledge what Patricia shared and bringing the reality back to say that it's all about being human. Thank you.
Thank you. I think, Amrita, you'd like to say something? Please go ahead.
Yeah, thank you so much. Actually, this is a very nice conversation. So I was also, saying the challenges we are facing, but also I think I was talking about the times we have to think about how innovatively, how inclusively we can, design programs for our community. I have given a couple of examples. Also, one good example I want to give from India, that is a CSC, Community Support Center. That is a if I talk about our Global Fund supported Vihan program, there are 319 CSCs spread across the country, and 10 specifics are typically dedicated for the transgender people who are affected, or who are, living with HIV. So they are not getting only health related care, but also they are getting the facility to link with other benefits, other healthcare opportunities, the welfare schemes, and everything. And also, to linking them to various other facilities like in insurance, small scale business, and all those stuff. So I think now we have to be slightly think about beyond HIV specific, intervention services. Even we are or you are doing HIV AIDS intervention, but please keep some space where diversity is included, where populations who are already discriminated and then they are labeled with HIV. Definitely, you can well understand how the level of discrimination go, like many times. So considering all this, this is a humble suggestion to all of you, that even in typical HIV/AIDS or health program, we can involve the community and we can identify their challenges and we can do it accordingly as per their need. Thank you.
Thanks, Amrita. I see Joyce also wants to come in. Come along, Joyce.
Wow, thank you so much, Yumna. Very interesting discussion going on, and many thanks to each panelist for really speaking passionately about the issues. And I'm really particularly keen on the issue that Patricia spoke about on the FGS. I must admit that I didn't know much about this. I don't know why, but as you make reference, Patricia, that this is one of the neglected diseases that not necessarily means the disease is neglected, but the women who are going through this. So that is something that is going to be my key takeaway from this session. Also, I'd like to come back to a discussion that Patricia had mentioned, that tomorrow is actually the International Women's Day, and the theme is digital innovation and technology for gender equality. And I just wanted to say that we really need to be careful about, embracing innovation, embracing technology going forward. The general assumption that all adolescent girls and young women are social media gurus, and they all have access, we all have access to smartphones, and we all can access data bundles. So everybody has now gone into social media messaging, social media, targeting the adolescents and young people on social media only, without necessarily going to the ground, as always. I think Patricia mentioned that innovation doesn't necessarily mean coming up with something new. And so I wanted to mention that it's very important to be careful not to leave behind other women who do not have access to digital, to smartphones. And digital divide is slowly becoming a gender issue, as we know that not every young woman or not every woman has access to a smartphone, can have control to a smartphone, can afford data bundles to access digital platforms. I think from where we come from, I first got my first smartphone was when I was in campus. So the general assumption that everybody is there with the digital era and the digital migration is something that we really need to be very wary of, and to ensure that we are not leaving anybody behind and widening the gap on inequalities. Thank you.
Thank you, Joyce. It just made me remind myself of the time when, at first, what did we have? We had access to computer rooms, not even our own computers at that time. So I'm revealing my age, but it's really important, because we really need to move with the times. Otherwise, we are going to be left behind as women, and so we need to make concerted effort to make sure that women are, updated. But there's a comment from a listener, and I'll read the comment. The issue of HIV in women is beyond caste, creed, and color. And we have not understood from COVID even that we need a global response for HIV. We need global approach rather than regional advocacy. I was wondering, anybody would like to respond to that? Amrita, you might want to respond to that?
Yeah, thank you so much. That's a wonderful comments or question I can address. That is because, I am associated with, if I give example of a trans woman from that lens, beyond yes, considering the typical definition of woman, definitely we are also women. So if we think about the challenges we have been facing regionally, globally, everywhere. So, I mean, this is my suggestion that not to limit it within geographical boundaries. I mean, if I talk about my own example, if I could think about only the trans woman from my own country, then I could not be able to, work as a co-founder of this global trans group. And so that is the thing, actually. I mean, you have to work at multiple level. Definitely, you have to include your grassroots level community members and everyone from the community to run your intervention, to do your, whatever activities at your own level, at your national level, regional level. At the same time, we need to have a global voice, because I mean, if we, for example, did not have this global platform for the trans women, we could not implement important program like Teach, where we could implement a very innovative training program for the translate organization for Latin America, for Asia, and the African countries. So this is the thing. At the same time, we are working in our own country, in our own organization, with our own community, and definitely we have to think beyond, in terms of sustainability, in terms of raising a global voice, in terms of like one movement together with other. I think each and everything is important. Thank you.
Thank you, Amrita. This is Patricia. I think I would also want to just contribute to this, just a reflection, and thank you very much for that comment, that yes, indeed, HIV cannot be tackled just by having like a regional advocacy. We need each other. We need every sector, not just the health sector, but across sectors. When, for example, I'm talking about FGS, we need the people who are working on environmental issues, the WASH programs, to come in and create awareness, teach people how to use clean water and other forms of sanitation, so that we are also preventing. So HIV needs to be everybody's business. And even as we say that, we know that there are specific regions or geographies where there's a concentration of HIV. And it means that in those regions, we then need to put in more focus, more investment, and be able to utilize local solutions. And I always believe that communities have solutions, homegrown solutions to their problems. And as long as we continue to put our communities aside and start thinking like scientists, like the investors, we get it all wrong. So it's important that we bring in communities, listen to the communities, and begin the local actions that can be responsive to the issues that disproportionately place people to be more vulnerable to HIV infections. Over.
Thank you so much, Patricia. What I'm going to do now is just one more question, one more comment that I'm going to read that came through, and it says that much has been talked about. I think we now need to put things into action at the local levels. And at this point, I'm going to move straight into, because we're also getting close to the top of the hour, I'm going to move straight into our speakers and ask them for recommendations. What they think this action needs to be. And I think, Patricia, I mean, maybe if you could also just build on the point about homegrown solutions and connecting to other issues, particularly around the issue of allyship and partnership. So I'll go straight into Patricia, and then we'll move on to the rest of the speakers.
Thank you very much. As I was speaking, I said we do not have, a lot of evidence, to build a huge case on FGS so that we get sufficient attention and investment. So my number one recommendation would go back to researchers and implementers, that if we can be able to do community level kind of research where we have community participatory research and communities are able to identify what the issues are and what are the possible solutions that can equally be sustained at community level, so that we are not just looking at donor funding, but also solutions that we can be able to own, we can be able to include within our communities and implement them over time. The second one would be on capacity development. As we have said, it touches on a lot of key stakeholders. And when a particular disease is not known, it becomes difficult to tackle it. So we need to put in a lot of investment in just growing the capacity. And this includes the capacity building institutions to be able to have curriculums that are as comprehensive as possible. And my last recommendation would be integration. Where there are limited resources, let's do as much as possible to an individual that comes for us that when a woman comes in, can we offer as much as we can so that we do not have missed opportunities? And we also simplify our scientific language and speak the language of the people. Thank you.
Thank you so much. Can we move on to Amrita? What are your thoughts and recommendations?
Okay, yeah, thank you so much. So I have, yes, definitely I will give some recommendation, but also I will like to give some other, ideas, because sometimes we have to, think about from the, if I talk about from the feminism perspective, the feminism movement, the feminist movement is not very much different from the movement, from the struggles we all have been facing. The things is in inequality. The things is actually there is no inclusivity. The things actually there is no diversity and there is no respect for the diversity. I think that is I should be the same motto for the feminist movement as well. I think we also believe in the same. That's how we can connect the lines. In terms of recommendation, my earlier speaker already have told the data gaps. Definitely, that is one. And from the my community perspective, I will also say now we are doing a lot more advocacy with healthcare sector, with national and global stakeholders, that you have to include us. You have to include the community from the designing of the program till the reporting, till the CSS part, then the community support system, the monitoring and evaluation part. Everywhere community has to be there. Otherwise, any program is not going to be a success. And definitely, capacity building of the individual, the community, capacity building of the organizations working on the HIV and all the women or any other marginalized population. So I think, and also definitely last but not least, bringing changes at the policy level involving the community. I think these are certain things that we need to think from now on. Thank you so much.
Thank you, Amrita. Dr. Ntotleng?
Thank you very much. So I think my recommendation would really be to focus on how do we build agency in people? How do we build agency, especially in those marginalized, vulnerable people? And how do we do that? By starting with me, recognize my own power, my own privileges, and recognize how I use my power and privileges to build agency in those who are vulnerable. And I think, we really need to open up our conversations, honest conversations about power and privilege in our families, in our churches, in our communities, in our organizations, even as feminist organizations. We really need to start having real conversations about how do we use power as a healing tool and not as a tool to control and to exert superiority over others. So if we can look at more interventions that address power and privilege, that build agency in people, in young people especially, that would be a really good start to start flipping the script and changing the narrative and working towards healing. Thank you very much.
Thank you. Joyce, if you're still there, please, just 2 minutes before you run.
Oh, yeah, I'm still here. Thank you so much, Yumnah, and thank you to everybody. I think I'd just like to say that we don't have to wait until International Women's Day to talk about the inequalities that women in all our diversity face. We are not a homogeneous group, and there is need to look into the inequalities that are affecting different clusters of women at different stages of their lives. There is need to even offer support and to offer support and provide access to young women who are already living with HIV, because if we've been constantly being told about us being 5 times likely to contract cervical cancers compared to the general population, which constantly gets us scared, but also constantly there's something that can be done around such issues. So I know that inequalities and inequities constantly affect women, affect young women on a day-to-day basis, and therefore they need to be addressed urgently and not just on the 8th of March. There is need to give young women important access to the commodities that work for them. So give young women the ring, give women access and control to commodities, give back women the autonomy over our own bodies, and together let's embrace equity. Thank you.
Thank you so much to our speakers. And just in conclusion, I just want to say that gender equity is important in terms of breaking down barriers through understanding and acting on the structural intersections, creating barriers to agencies. It's so important that we grasp the concept that we don't need the barriers, that we can break those barriers down and we can attain equity. And equity is needed to reach our vision of ending AIDS by 2030. Thank you so much for joining us this was really a very quick conversation, but was such an important conversation, raising some very key issues of using power as a healing tool, looking at the person that's neglected rather than the disease that is neglected, looking at the transgender narrative and making sure that it's written with accuracy from lived experience rather than what we think and imagine it is. And then, of course, though, obviously making sure that women, young women, are part of the decision-making processes and part of the action that goes ahead. Thank you so much. From Frontline AIDS, we say goodbye.